Good afternoon, students. Variety is a species of life. Let me welcome you to a new system. Not that the others have been completed. This might infuse some kind of an interest in you people. Please follow the class diligently. And please do remember our logo, R.A.T.S. We are racing against time in pathology. I start with the case history. A 50-year-old male with a history of chronic alcoholism was brought to the hospital with complaints of bouts of hematemesis. He was in a semi-comatose state with a fruity odor emanating from mouth. Abdomen was distended with dilated capillaries and venules. In spite of vigorous treatment, he collapsed and an autopsy was performed. What is your diagnosis? Discuss the gross and microscopy of the organs involved along with a diagram. Discuss the pathogenesis, stages, and complications. Add a note on the laboratory diagnosis and the probable cause of death. The mark distribution and the total mark is given here. What is your answer? Good. The topic is alcoholic liver disease. And it can come to us as any of these: an essay, a short note, a viva voce, a specimen for discussion, chart, or a slide. And these are the subheadings under which we shall be dealing. And many of these can be independently asked as questions. So please do follow the class. The fatty liver. This is one of the first topics under the cellular adaptation. And I would like you people to go back to the original chapter. But until then, let us see what is actually happening. This is a picture of a hepatocyte. And these are the various metabolites that are brought into the liver and finally excreted into the plasma lipoprotein. The free fatty acids can be mobilized either from the adipose tissue or from the diet. From the adipose tissue in the case of starvation. And when it enters the liver, it is converted into fatty acids, then to triglycerides, lipoproteins, and finally plasma lipoprotein. There are a number of these stages which are given the digits 1 to 6. Meaning, at any stage when there is an obstruction, you find that the previous component will get accumulated. Free fatty acid, if it is not converted to fatty acid, then it remains so. Similarly, the fatty acid, if it is not converted to triglyceride, due to the deficiency of alpha glycerophosphate, this gets accumulated. And so also the lipoprotein. The various causes of the fatty liver are given here. It can be because of starvation, diabetes mellitus, that is number 1, and please follow the others. It can be because of increased esterification, conversion to cholesterol, a defective metabolism in alpha glycerophosphate due to chronic alcoholism or carbon tetrachloride poisoning, and finally, in experimental animals, orotic acid. In figure 6, you find that on the administration of orotic acid, lipoprotein is retained and not converted to plasma lipoprotein. So enumerate the causes for fatty liver is a very favorite and universal question, and this is the flow chart that you shall and will draw. The gross picture. The gross picture of the liver will be the fatty liver. The size is about 4 to 6 kg. In weight, it is enlarged, yellowish and greasy, and it is also shiny. The capsule is stretched. See, I can see the reflections of the light over here. And the cut surface is solid, yellowish and greasy. The knife will be passing through butter, literally. If you are not convinced, compare these two. This is a normal liver with a beefy reddish brown color, whereas this is a fatty liver which is enlarged and the cut surface is solid, yellowish and greasy. Capsule is stretched and shiny. And this can be a microscopic diagram. Initially, you find that fat is accumulated in the form of small vesicles, small vacuoles of fat. But later on, they all can join together, coalesce, and push the hepatic nucleus to the periphery. These are the strands of the hepatocytes, and around the hepatic venule, I am finding the fatty change initially. I would like you people to compare these two. This is a normal histology of the liver. What are the components? This is the central venule. This is a portal triad. And the zones are periportal, perivenular, and the midzone. These are the strands of the hepatocytes which are eosinophilic and they are being separated by the sinusoidal spaces. On the right is the fatty liver. What are all the differences that you people can see? 6 differences. It is a teaser for you people. See whether you can identify. Yes, the cells are ballooned out. They are large, round, vacuolated, and empty looking. The nucleus is pushed to the periphery. Here, the sinusoidal spaces are there, which are not discernible because of the compression. And small vesicles of fat have joined together to form large spaces. This is a portal triad, of course, and still I am not able to see the radiating strands of the hepatocytes because they appear more or less solid owing to the enlargement. This is a higher magnification of the same. This is a triad, and here the hepatic cells show a ballooned out cytoplasm. Sometimes what will happen is there can be a rupture of these cells and the fat can come out. Once it is out, it creates a foreign body type of reaction. Pure Robbins calls them as fatty cysts. So there can be fatty cysts. The features are all given over here: vacuoles, peripheral nucleus, compression of the sinusoids, fatty cysts. Architecture is retained. I'll come to the word architecture later on. And it is a reversible change. If the patient stops alcohol, probably the liver will revert back to normal. And this is a special stain that is done. Earlier also I have told you in the description of the slides that the vacuoles are due to the dissolution of the fat. When the tissue is passed through the normal tissue processing, it is dissolved by alcohol. Therefore, when it is stained, it appears empty. On the contrary, when we do what is called as a frozen section in a cryostat, the step in alcohol is bypassed. The fat is retained and it can be demonstrated by stains such as oil red wool. So there is a red color to the fat. There are three basic stages. One is the fatty liver, second one is alcoholic hepatitis, and the third one is cirrhosis. The alcoholic hepatitis usually follows the fatty liver as a sequence and it ends in cirrhosis. And when I say alcoholic hepatitis, these are the components that we should have in mind. One is the necrosis of the liver cells, Mallory bodies, inflammatory infiltrate, fibrosis. I repeat again, liver cell necrosis, Mallory bodies, inflammatory cell infiltrate, and fibrosis. We shall try to describe these. This is a picture of the Mallory's hyaline. I find that the hepatocytes are all enlarged and there are some eosinophilic inclusions that are found in the cytoplasm, irregular. The description is they are large, irregular cytoplasmic inclusions described as candle drippings. And they are supposed to be aggregates of the filaments of pre-keratin and occur due to the depolymerization of tubulin within the cells. The same thing is described over here. So the cells are large and they have got irregular cytoplasmic eosinophilic inclusions. Irregular, described as candle drippings. But then a word of caution. Alcoholic hepatitis alone is not the cause for Mallory's hyaline. It can be found in alcoholic cirrhosis, biliary cirrhosis, Wilson's disease, Indian childhood cirrhosis, focal nodular hyperplasia, and hepatocellular carcinoma. Mallory's hyaline by itself can be asked as a question, or sometimes one of my favorite MCQs will be Mallory's hyaline is found in all conditions except, and you should be familiar with the panel of causes for the Mallory's hyaline. And they are due to the degeneration of the intermediate filament. Please remember that. The third one is the cirrhosis. As I told you, steatosis or fatty liver, hepatitis, and cirrhosis. Alcoholic means 60 to 80 grams of alcohol per day in male and 20 grams in women. And when this is going to be persistent, there will be what is called as alcoholic cirrhosis. Initially, the cells will be producing fibrous septae. And these fibrous septae are supposed to be originating from the smooth muscle cells of the blood vessels or the sinusoidal spaces. And they form what is called as myofibroblasts. So where do you get this fibrous tissue from? It is from the smooth muscle cells or the blood vessels or the sinusoidal spaces which produce the myofibroblasts. This is a gross picture of a liver with cirrhosis compared with the original one. You can just run your hand through, you find that it is very nodular, irregular, and I can see the firm consistency of the liver. There are multiple small nodules less than 3 millimeters in size. We call it as micronodular. When it is more than 3 millimeters, it is macronodular. Sometimes both can be seen and it is called mixed nodular. And this is a cut surface again. I am able to see multiple nodularity throughout the surface. So this is a hepatic parenchyma and these are all being divided by the fibrous septae, the external surface and the cut surface. Liver is firm, it is contracted 1 kg in weight. Usually you find that there is a decrease in the size of the liver. The patient will be happy, but actually he has gone in for an irreversible damage. The surface is nodular and it is uniform. One of the features for diagnosis is all the lobes are affected equally. Right lobe, left lobe, caudate and the other. And the surface it has got a pattern called the hobnail pattern. Hobnail is something like a boat pin. The cut surface shows a lobular parenchyma. So look at the pale areas. These are all the regenerating parenchyma, and the darker areas in between are the septae. Here I can see the septae, and this is the cut surface of a liver in cirrhosis. And look at this point, the entire cut surface is involved. And which is the parenchyma? The paler area is the parenchyma, and the darker area is the septae. Externally, there will be a hobnail pattern. And look at this, compared with one of the original pictures, I showed you the sinusoids, but here I am not able to see anything. And these are all strands. A special stain called the mesenteric has been used. I am able to see the blue colored collagen. And these are all various nodules of the parenchyma. There is a little bit of residual fatty chain that is seen. There is a collapse of the hepatic strands. The fibrosis is replaced by collagen types 1 and 2, and it is bridging from portal to central or portal to portal. And there is a regeneration of the hepatocytes. The liver is one tissue that is capable of immense regeneration, and therefore it multiplies, producing a nodular pattern and a hobnail pattern. Effacement of architecture. The favorite word, this word we must use. In fact, even in the earlier picture, I would have mentioned there is an effacement of architecture. Compare this. This is a normal liver. I am seeing the central vein, portal triad, radiating strands. But here, look at this nodule. There is no central vein that is seen. There is a small nodule over here. And in this again, there is no portal triad. Sometimes I might see two central veins within the same lobule. And these are all broad septae of connective tissue. Initially, you find that it will be in small spurs. But later on, there is a collapse of the hepatic parenchyma, as in this case, and it is replaced by fibrosis. We call it as bridging fibrosis. And finally, there is a fully developed cirrhosis. Now, what is the basic pathogenesis of the cirrhosis? It is the alcohol, okay. You find that the alcohol can stimulate collagen formation. Ethanol is the main component, or sometimes its metabolite acetaldehyde. So either ethanol or acetaldehyde can stimulate the formation of collagen. The alcohol can induce a liver injury by immunological action of either macrophages or the T cells. And the ethanol can induce activation of some enzymes such as prolyl hydroxylase. So these are the various mechanisms by which there can be a tissue damage, a regeneration of fibrosis and cirrhosis. The morphology, it begins as a fatty liver, later on it is shrunken, and there is an inverse relationship between fat and fibrosis. Initially, this will be delicate strands which are perivenular, periportal, but later on with the destruction there is replacement by fibrosis. This is again a pathogenesis, I will not be repeating it, but these are the causes for the death. It can be ethanol, acetaldehyde, P450 activation, or lactic acidosis. This is the architecture. What do I mean by the word architecture? It is a relationship of one part of the tissue to another. Central vein, radiating cords, portal triad. This is the relationship, which is totally lost over here, and that is called as effacement of architecture, and the same features are repeated for your convenience. What are the laboratory findings and the causes of death? The common laboratory findings will be the SGPT is increased, serum bilirubin is raised, serum alkaline phosphatase is raised, patient can be having a macrocytic anemia, hypoproteinemia, reversal in the albumin globulin ratio, and there will be the loss of the clotting factors because the liver function is depressed. So these can be the common findings. But the cause of death can be a hepatic coma. Because the nitrogenous products are not metabolized, it can lead to a hepatic coma. Hemorrhage, particularly from the esophageal varices. Intercurrent infections, decreased immunity, hepatorenal syndrome, and rarely a hepatocellular carcinoma. All these can be the causes of death. Ευχαριστώ. Gritias Tibi.